Good afternoon. You ready?
Yeah, I'm ready.
Okay. Good afternoon. I'm Mark Snowden. I'm the Chief of Psychiatry here at Harborview and an Associate Professor in the department and Vice Chair for Clinical Services. And I want to welcome you to Grand Rounds. And it is my pleasure to introduce our speaker today, Grayson Norquist. Dr. Norquist is the Vice Chair at Emory University Department of Psychiatry and Behavioral Sciences. He's the Chief of Psychiatry at Grady Health System and the Chair of the PCORI Board of Governors. Prior to joining Emory, he was Professor and Chair of the Department of Psychiatry at the University of Mississippi School of Medicine. He served in a number of leadership positions at the National Institute of Mental Health, which is where I actually first met him, including when he was the director of the Division of Services and Intervention Research, the division responsible for clinical prevention services at NIMH. He's been a member of several journal editorial boards, including Psychiatric Services, the Archives of General Psychiatry, and the Journal of Mental Health Policy and Economics. He's received various national and government public awards, including the NIH Directors Award, the NIH Special Service Award, and the National Alliance for the Mentally Ill Exemplary Psychiatrist Award. He has his BA from the University of Mississippi and a Master's in Public Health from the UCLA School of Public Health and an MD from the University of Mississippi Medical Center. His research focuses on improving mental health services for underserved populations and the development of quality measures. And he's here today to speak to us on a titled Transforming Healthcare and Community Health Using Patient-Centered Research. So please join me in welcoming Dr. Norquist.
Thanks.
So, thank you, Mark. And as you can see, I've been around the block. So, yeah, as a kid who grew up in Mississippi during civil rights time and stuff, my life has kind of been devoted to really focusing on improving the lives of underserved populations. So I've been around the U.S. trying to do that, and now I'm in Atlanta. I will try to stay, I tend to move, and I've been told I have to stay in this little space right here or else I mess up those listening online. So I'll do my best to do that, but I like to move around, so someone may have to point me back in this direction if I do. The purpose of the talk is basically, in some ways I feel like I'm kind of talking to folks who are already doing this. So what I hope to do is to enlist a little bit of discussion. I'm going to talk some, but I hate to go to talks in which people spend the whole time talking to you. I'd rather hear from you. So one of the reasons I like to go out and give talks about some of the things I'm doing and what we're doing at PCORI is to get feedback. And we used to do that in the early days of PCORI. We used to go around. In fact, we did this at Seattle some years ago and listen to the folks out there about what they thought we needed to do in healthcare. So I hope that we'll have plenty of time for discussion and for questions. So I hope you will engage with me on that. So here's the topic. You've already heard my conflicts. It's really also, I say this, not so much my conflicts, but also my biases, so that you understand where I may be biased in certain directions. So I'm a vice chair at Emory, but my day job is at Grady Hospital, which is a Harborview for Atlanta. It's the large city public hospital, and I'm the chief of the psychiatry service there. And I'm the chair of the Patient-Centered Outcomes Research Institute Board of Governors. For those of you who don't know what PCORI is, briefly, it is a non-federal agency, although we get our money from the federal government and a $2 tap on every insurance premium. That's how we get our money, which you can imagine one of our key stakeholders is the insurance industry, who feels we should be doing their work as opposed to anybody else's. But it is a component of the ACA, which means we're trying to break ourselves out of that. As you can imagine now, that's the Affordable Care Act, or also known as Obamacare. So it's important to be seen for what we do. And I'm on a number of American Psychiatric Association committees and boards, but primarily I'm on their foundation board and also the chair of the APA Council on Quality Care. So as you can see, one of my big interests is improving quality care, what we do in psychiatry. Okay, so usually what I like to do, because most people start eating and then they start falling asleep and they're not sure what the whole point is at the end. And I've learned over time you get maybe 2 or 3 points out of any presentation, and hopefully you'll pay attention. But the point is that there are a couple of things. And this is kind of, it's kind of like mom and apple pie in some sense, but patient-centered is important. but so are other stakeholders. And so, you know, sometimes the problem, and one of the things I've gotten to at this point in my career is kind of giving you lessons about what it's like to have, you know, lived through a variety of political battles and things like that over 30 years. So maybe you won't fight those same battles, or you'll have a better sense about what to do. And also, as you see, I've put my glasses on because now I realize at this age I can't even read the damn computer screen. So anyway, so key to this is patient-centered outcomes research or comparative effectiveness research, which I will talk about. Now, one of the things I want to point out that many people will say, I had a nice conversation with Mark Sullivan this morning too, is that it's not all about just simply about comparative effectiveness research, patient-centered outcomes research, when we're talking about patient-centered care and how we improve and make our system more patient-oriented. It's a much broader perspective, but I'm giving you a piece of this broader perspective of patient-centered care, and we're really going to focus more on how you develop evidence about what to do in a clinical encounter. Okay, so when I'm talking about patient-centered care, don't assume that I'm trying to be very narrow-minded about what makes a difference in improving patient-centered care. We'll talk a little bit about that. So, and it's also not just about learning what to do, but what not to do. We do a lot of stuff we probably should not be doing, and I'll give you a little taste about that in this thing that we actually did in the APA and something that the internal medicine people started, which is called Choosing Wisely, and we'll talk a little bit about how we got there. How patient-centered outcome research has made a difference, lessons learned, which is going to kind of be the what the bumps are in the road, and the opportunities. And yes, there is still a life even after the selection. There will be a life. So I know we all believe there won't be, but there will be. Okay, so why is this important? Why should we even care about this, other than the fact that it's very important to be patient-centered and do the right thing for the patients, because at the end of the day, that's what healthcare is supposed to be about. Well, we spend a lot of money on things that really don't improve health. I mean, and most of us know that who work in healthcare, that this is going on all the time. We're incentivized in the wrong directions to do things, and we're not spending money in the right direction. We waste time in our everyday clinical practice on things that probably don't lead toward things that the end user, i.e. the patients or their caretakers, want. And unfortunately, sometimes we may be actually doing harm when we're doing that. So there's a lot of treatment options, but it's unclear what option is best for someone specifically sitting in front of you at that particular point in time. Okay, implementation issues are also important, as is medical decision making. But when you're trying to make a decision, you've got to have some evidence. Either that, you might as well take out a coin and start flipping it, which unfortunately is probably what we're doing most of the time anyway. And then the patient focus is key, because we know that if you have engaged patients who are fully informed and are part of truly their health care, it does lead to improved outcomes and quality of life. Okay. So let me just give you a little history in mental health. So PCORI and what we do at PCORI is across all of health, but it's not like mental health hasn't been kind of in some ways a little bit of a leader in this. And I'll take you back a little bit to my story. As Dr. Snowden told you, I had been at NIMH, where I was there for 15 years and ran the division that was the division called Services and Intervention Research, which still exists. Now, I'll just give you a little sideline so you can see what you get for your money from the federal government. But the federal government loves to go around and use acronyms, right? And so at the time when we started this division, Steve Heineman had come and was the director there, and Steve did a big reorganization and wanted to really put clinical research together with services research to start really for the first time to think about how do you translate clinical research into practice, basically, to make a difference. And so we were changing up the divisions. And so in my division at that time was going to be basically what was considered epidemiology research, treatment research, and health services research. So Steve, in his own, for those of you who probably don't know Steve, but in his own kind of dry sense of humor, was going to call me the Division of Epidemiology, Treatment, and Health Services Research, which the acronym would be DEATH. And I said, no, that's not what we're going to do. So I quickly thought up, as you can imagine, this is what you're paying your federal employees to do, is to think up an acronym that sounded better, which was DESIRE, which is the Division of Services and Intervention Research. And actually, it still exists to this day. So one creative moment in my life that I figured that out. So anyway, we started looking at this issue about how do you take what we learn in clinical research, make it relevant to what people are doing in practice. And a very important little, the federal government loves to have meetings and produce books, and then we put these books on our shelves. But this report was actually a seminal report that still exists. I have copies of it. It's called Bridging Science to Service. And it was really set the ground floor for changing what we were doing in clinical research and services research at the National Institute of Mental Health. And so what we did is it basically launched comparative effectiveness research in mental health. Prior to this time, this is about 97, 98, the largest clinical trial in mental health was around 300 people, okay? Very specific population, not something you could generalize. And so we looked at this and thought, you know, this is not going to get us the answers that we need for the people that we see with many comorbid things. So it really launched this clinical effectiveness research in mental health. It focused on the needs of stakeholders. For the first time, we actually brought in, at that time, patients and other people. Primarily, I will admit, our stakeholders were the funders, the Medicaid directors and others, which drove some of the questions that we sought at that time. And we also recognized that it wasn't just about improvement, that it's about remission. And so, for example, in the STAR-D trial, for those of you who know, that looked at the comparison of the variety of different interventions that for major depression, the way that, you know, the drug companies look at this and decide whether something is worth, you know, putting on the market and what they get approved by the FDA is a 50% improvement, basically, right, on the HAM-D or something else like that. Well, John and others came and said, we have to do better than that. We don't say to people in practice, well, we're only going to get you 50% better. Is that okay? You know, so the point was to drive our treatments toward remission, because that's what people want and what people expect as a result of our treatments. So actually, interestingly enough, for the first time, we really focused on that as an endpoint. This, I don't know why adherence is here. It shouldn't say that, but that was the point, is that it's remission, not just a change in the symptoms. And then we also went into other settings. Traditionally, mental health research had been done at the VA. Not that that's not a real world setting, but that's not where a lot of care, particularly for things like depression, happen. And so we went into primary care settings. But this, at the time, folks, was novel, is what I would tell you. And this was about, you know, the late 90s that we did this. So that was the beginning in mental health of this focus, in some ways, if you will, on comparative effectiveness research, but moving in a direction toward patient input on what we were doing. In fact, just before I left NIMH, this would have been in 2004, we started mandating that the old centers that we used to have, until the next director came and got rid of those, unfortunately, which I didn't think was a good idea, but we started mandating that a component of that center must have a community component that was funded and be a part of it, so that we were ensured that people in the community were a part of what they were doing. All right. So what is this? For those, many of you probably know what it is, but for those of you who don't, I won't embarrass you and say who doesn't know, who knows, or something. We'll just go over it. So comparative effectiveness research is, you know, basically the comparison of a variety of different interventions. So it doesn't have to be just interventions. You could argue this is preventive interventions. It can be health system interventions, right? But it's a comparison of different things. And it's not comparison to placebo, for example. What we're trying to do is compare things that we believe are the right things to do to figure out which one may be better. But it's not just whether it's better, but specifically looking at for whom and under what circumstances. So that's where it carries it a little bit more than is just something work or not work. It's not just whether it works or not, but whether it works for certain populations and what kinds of conditions. What's the P added on to this is the issue that now what we're looking at is from the patient's perspective. And I will also add caretakers, because many patients have caretakers, particularly children or older people, or with diseases or illnesses or whatever that prevents them from being fully engaged in their care. They have caretakers. So caretakers are often very important in this as well. But what is it that they want as an endpoint of what's happening to them? And so what we're doing now with this is to start to bring the, if you will, the end user of this into the discussion about what do you want from this, as opposed to what we think you should want from this. Okay. So where was this first? I'm just giving you a little bit of history here. It was first mentioned in Section 1013. You can read this of this Medicare Act. This is the first time this was actually mentioned in federal legislation. Contrary to some opinions, I just put this out, it does consider heterogeneity of treatment effects and stakeholder preferences. Why is that important? Because there are many policymakers, and there's some people who do not believe in comparative effectiveness research because they believe that it sets everybody up to some mean, and that's what we're basing it on, therefore excluding certain people. And so they say this should be, I mean, it's interesting, we have to have these discussions with people all the time about trying to explain it, but actually we are able to piece out subgroups, particularly in very large studies. The other thing I often point out about the importance of these very large comparative effectiveness research trials is that they also can drive what's done in basic research. And so you're thinking, well, how does that work? Well, the reason it works is that imagine you have 4,000 people in a large comparative effectiveness research trial, and there are subgroups within those 4,000 who don't respond or respond in a different way or something else. Then there may be something unique about that group that then you could say to the basic science folks or the people on the other end of the spectrum, what's unique about these people? What's different? Is there some particular intervention that might be developed that might be different for this group? So if you will, there is a feedback loop in a way that can come from large studies like this. One I always argued about, particularly, to be honest, is when there were budget crunches and money was going toward basic science, we had to make the case for why what we were doing was as important as what was being done there. So the next slide is going to go through this. I'm just setting it up. How do you do it, and what's wrong with the current research? I added in this line because we're in Seattle, so you guys are, Microsoft and all that stuff. I don't know how many of you know who Andy Grove was, but he was a co-founder of Intel. And he was he had to struggle with treatment of prostate cancer. And what he recognized in, the 90s was, what the heck is wrong with the healthcare industry that in the semiconductor field would never not know what to do? We compare our data across our competitors all the time. Why would you not know what to tell me what to do in prostate cancer? So it was quite an eye-opener to him. He wrote a op-ed about this to kind of wake up, in some sense, people in the healthcare to get real like what people are doing in the rest of industries. And then what to study? That is the biggest question. So we don't have all the money in the world. And the question always comes up, what comes first and what should you study? Okay, so I'll tell you what some people have recommended. I'm not going to ask you personally, but I'm going to give you a little blank space to think about. If you were asked what would you list as your top 3, what would they be? Okay, so I will tell you before I get into that, remember, we started with the Bridging Science to Service. It started our CER trial. So why did we, at that time, choose the 4 topics that we chose at that time were CATIE, which was the schizophrenia trial. It was, are any of the new, at that time, antipsychotics better than the old ones for the treatment of schizophrenia? The other big trial we did was STEP-BD, which was in bipolar disorder, right? So what are the interventions that work best for depression and for mania? The third trial was, okay, we have all these interventions for major depression. Are any of these better than any others? And there was all this lore, if you have a little bit of this, then you should use this with this side, it works in this way and all that. Are any of these, is that really true? And do any of them better than the others? And then the fourth one was a treatment of depression in adolescence. So why did we go with those? Well, I have to admit that at the time, we did not engage fully the consumers or the patients at that time. We basically went to, the academicians, and we went to the funders, and particularly the Medicaid folks, to ask them what were the biggest issues for them. So if you look like in schizophrenia, it was obvious. The Medicaid people were spending a lot of money on these very costly second-generation antipsychotics, and it wasn't clear whether they were really better than the first generation. Okay. The second one was about, obviously, bipolar disorder, but in the bipolar field, there was great unanimity about the fact that we just don't know what to do, and we don't even know the natural history of the disorder. And then the third one, of course, was also driven by the funders to some degree, because there were a lot of these new expensive SSRIs, and the question was, were any of them really indicated more than the others in this case? So that's how we got there. I had to, though, disappoint some folks, right? There was no anxiety disorders in there, right? And it's not like anxiety disorders are not a huge problem. So basically what we had to sell was, at the time, we got to start somewhere. These are the ones that people are pushing. The next one on the list will be anxiety disorders. Unfortunately, I left after that, and then somewhat of the CER program kind of collapsed. So that did not kind of carry out, but it just shows you that at times you have to make choices at some point, and how do you decide what to wait first? Okay. All right, what's wrong? So what's wrong still with what we're doing basically in clinical research? So one thing is that basic research is often not judged on its practical impact, right? Although I would argue that it should be. And that clinical research must be, but sometimes is not. And so I think that before we launch on clinical research, that one of the most important things is we should be able to say, this has an important potential impact on population health or on people. Okay, but you would be amazed at how much I spent, as I said, 15 years at IMH, how much we funded that at the end of the day, I would say, did I really think that was going to have a clinical impact when I started it? In a big way. Okay. New clinical research is often not put in the context of prior research. It's amazing how little kind of assessment of what is going on in this general area is not done and understand what's already there. And or is not relevant to the real life of patients. So that's this issue about having patient input on what do I want really from this. Okay. Focus is often not on big health problems. This may be your particular area of interest in this small little area, and that's what you want to do your research on and convince a group of people you can do it. But should we not, in some sense, be saying, these are the key big health burdens, and these are the ones where we should be putting our money initially and focus on that? Studies are too small and inadequate in length. So what do you think? Several years ago, there was a study done of the sample sizes for clinical research. And what do you think was the average, basically the median sample size per arm for most clinical research studies? You could guess, and then you'd be, unless you read the thing, would know. I didn't either. 36. I mean, that's the median size, and you can imagine 36 per arm is not going to get you much of a robust result, right? But that's the kind of stuff that's being funded and a lot of money is spent toward. And then one can argue about the length of the study. It's pretty clear that the magic is 5 years. Why is it 5 years? Because that's just generally what NIH and others have decided, and we'll cut off after that. It's not a very thoughtful way of thinking about it. There may be some trials that could be done in a year or two, depending on how you want to do it, some that may take 10 years to get the right kind of outcome, specifically if you're looking beyond these surrogate markers. And by the way, an issue about surrogate markers, those often are not very appealing to you if you're a patient. That's not what you're looking for. Oh, we're going to give you a surrogate marker, and that's not what I'm interested in as a halfway point or some indicator that doesn't mean anything to me personally. So this takes too long to produce the results. The other big issue is not transparent. A lot of clinical research is not transparent about what's being done. The data are not available. What you will see at PCORI, and I will tell you nationally what's being done, is a lot about what we call open science, which is to really make data available to everybody, to make this very usable for others, and have much more transparency about what we're doing, what the study was, exactly who the sample is, and this kind of thing, because that's the only way we're really going to understand the accuracy of many of these. Okay, and often not feasible. And this is a big issue. If you're the funder of research, it's really critical that people can carry out what they say they're going to carry out. So there's always this game of promising a lot, and you have effect size, and you say, I'm going to be able to do this, and we have all these people signed on, and we're definitely going to be able to get then 2 years later, you find out they're gotten a third of the sample size they promised to get by that point. So what do you do as a funder? Do you keep funding it because you've already put some money in, or do you cut it off at that point and go forward? So in the old days, we used to just keep funding it because we go, well, we're into it a little bit, let's keep going until we get it. Then you're 5 years down the road and you're only halfway there. The rule these days is to cut it off. So what I would tell you is if you're serious about doing clinical research, make sure you're pretty convinced you're going to be able to get your sample size, because most everyone agrees it's time to cut it off if you're not. Okay. And I do want to say something about observational studies, because observational studies are very easy to do. Now, the problem with observational studies is that they do tend to overestimate effects. And I think that's one of the problems. But they're very valuable for giving you a signal about something and can be very helpful. They're also very helpful to look at long-term effects sometimes of an intervention. So it's not that they're not good. You will find a lot of methodologists who argue strongly that you should just do randomized controlled clinical trials. That's the gold standard, and it's the only thing that gives you a for sure answer. But often those are not feasible, and they're not realistic in a lot of ways, and so observational studies are the way to go. And I just put this line in from Johnny Anitas, those of you who know, is down at Stanford, used to be on our methodology committee for PCORI, who says that most research findings are false and most true findings are not useful. That's a strong argument he makes, and wrote a paper this last year about this you might want to read. That's quite, and some of these points are also taken from his paper, but I think he makes a pretty convincing case about some of the problems and would argue that clinical research needs to focus much more on clinical impact and input from the end user. Okay, what to study? So if you were given the task, which some of us have, like myself, been told, you need to come up with a list of what you would study as far as the key questions that you struggle with, for example. Now, we cut across all of health, and I'll show you the IOM list of 100, the top, they put them into quartiles. So there's the top 25, and I'll tell you what those were in mental health. One of the problems is, though, that stakeholders differ on what's important, right? So if you're a payer, if you're a health insurer, what you really want to know is, should we pay for this or not pay for this, right? But if you're at the level of a patient or a clinician, you're like, what do I do with this person who's sitting in front of me? And whether should I use this or not? It may not be, as a health insurer, what you necessarily want to hear. It may be used for a small group, but as a health insurer, what they care about is yes, no, that's it. And that can drive in big ways the way in which you design your study and what you want to do. And so we have been, quite honestly, in this battle as we listen to our stakeholders about what's important to do. There are those who say, here are the questions, here are 10 questions, take these 10 questions, go out there and get somebody to answer a yes and no on each one of these questions. Some of us would argue, well, that's not very informative. It may be informative for you as a decision about making a decision on covering something, but is that really going to be helpful for a patient to make a decision about, or a clinician or anybody else who helps take care of that person? So that tends to be somewhat of a struggle sometimes in what to decide to do. Okay. So if you had to pick the top 3 things in mental health that you think are a big question, just think in your mind for a minute, what would you pick? And let's see if they match with the IOM. Now, the IOM was not only mental health people, okay? It was a group of a variety of people who cut across health who came up with this. But in the top, I have to read this now because I couldn't remember myself, but in the top 25, there were 3 from mental health. So I'm hoping you're all thinking, if in your clinical practice, what you do, what would be the most important? Now, this cuts across children and adults, okay? So if you're not in the child area, you may not be thinking in that way. So I will give you a hint that some of them are in children. All right. So let's see. Let me see if I've got the next. Yeah, I think my next slide. Yeah, okay. So the top 3 in the top 25 for mental health, the number 1 were strategies for management of behavioral problems in Alzheimer's. So, I mean, I'm a geriatric psychiatrist, so that's a very important issue, right? The behavioral problems. We struggle with what is the right way to take care of that instead of giving everybody a bunch of antipsychotics and then giving them whatever other problems they have. Second one was ADHD, but specifically primary care strategies. So what to do about treating ADHD in the primary care setting. And the third one was wraparound home and community service for SED children. And if you work in the child area, this is a huge issue. A lot of money is spent on community interventions for kids with severe emotional distress. And I would just say that, you know, at the time now, think about how you're going to design a study like that. That's not necessarily easy. That's a pretty broad topic, right? And so it's very hard to come around that. But those were the top 3 at that time. And in the second quartile, there were 5. One was treatment of autism, which is probably driven, and now it's a public health problem, but is it bigger than schizophrenia and some of the others? One could argue that. Identifying and treating emotionally developed disorders in 0 to 3-year-olds. So what was being driven there were by the pediatricians who didn't know what to do with the very young little kids who had developmental disabilities and other things. I'm not sure we still know what to do, but that's a pretty broad topic to cover. And then the other one, interestingly enough, at the time, and this was 5 or 6 years ago, mindfulness-based interventions for anxiety and depression, but also for other medical disorders, and whether that made a difference in the care of like cardiovascular disease and other chronic illnesses. And the treatment for major depressive disorder in children and adults. Now that's very broad treatment, right? So we just actually at PCORI launched some studies on treatment resistance, what to do for treatment resistance in people who are treatment non-responders, I should say, with major depressive disorder. And the final one was treatment for PTSD. So those are your top 8 out of 50 that, unfortunately, 8 out of 50 across all of health were mental health. What was interesting to me at the time, this was some years ago, but falling in the bottom 50 was the topic of opiate use, which now would probably rise to number 1. And so one of the lessons that you learn is that priorities change over time. And sometimes you start a priority and you may be into the study and it may not be. So let's give you an example of that. On this list also was hepatitis C treatment. At the time, there were not the new antiviral drugs that now basically, theoretically, we don't still know yet, we hope it turns out to be that way, cures it. So at the time, we could have launched a variety of studies looking at interferon and a variety of other things, which would not necessarily be relevant now. So this is one of the other things you deal with when you pick topical areas. Okay, so those are things where we make comparisons. But then I also mentioned to you what should not be done. So we do a lot of things in practice right now. So I want you to think for a second about what do you do in practice, or that maybe, let's put it this way, what do you see the residents doing, or what do you see the primary care people send your way that they shouldn't be doing, or something like that, and think about that for a minute. So a couple of years ago, the internal medicine folks, their foundation got together and decided they were concerned about the overuse of imaging and a variety of other things, and so they started this thing called Choosing Wisely. And so they came to the American Psychiatric Association and said, well, what would you guys and women say about this in mental health, right? Now, we went about it the wrong way. I mean, what I would say is how you pick the topic. I'll tell you how we picked the topics, which was not the best way to do it, but it was very expedient. We were on a timeline to do it. And so the way we did it was not to go out and ask a large group of people, you know, what do you think about this? Ask patients what they thought, these kind of things. We simply took the Council on Research and the Council on Quality Care at the time. We asked the two councils to come up with your top 20, and then we went through those and we kind of did a Delphi process and weeded it down to 5, and then we took it back to the assembly, basically, and some others and said, what would you vote? And basically we came up with 5. Now, some of you may know what these are, but if you don't, I'll be curious to think what you think about the final 5 that came up. Understand also there was a lot of argument about, well, we don't think we should put that because I do that sometimes. So, you know, if you say that, then that means we're not going to be able to do it at all. And this, I hope that's not what's driving our healthcare, but unfortunately it is to some degree. All right, so here, let's see. Okay, key is what, okay, so I've already said this. Here are the 5. Okay. Don't prescribe antipsychotics for any indication without initial evaluation and appropriate ongoing monitoring. So what happened? What do you think came? So everybody's like, well, what does it mean, initial evaluation? What does it mean, ongoing monitoring? So now we had to put out some statements about what does it mean, really, to do initial evaluation and appropriate monitoring. Don't routinely prescribe 2 or more antipsychotic medications concurrently. And you probably already have that as a performance measure, quality measure anyway. We're tracking that as well. But there are exceptions, right? So you have exceptions if you're obviously transferring somebody from one antipsychotic to the other, you're obviously going to be on 2. And the other one is what? Do you know what the other one is? The other one is if you've used 3 successive trials and a failure, and this is the only thing that worked, that kind of counts. But is that really, should that really be the case? I don't know. We don't have good evidence for that. That's the problem. The whole point of all this is we don't have the evidence to support some of this. Don't prescribe antipsychotics as a first line to treat behavioral psychological symptoms of dementia. That's something we were talking about earlier is a big issue, widely used, but there are exceptions, right? When the patient is so out of control or having some kind of problem that without the use of these medications, it would just be no other choice. And don't routinely prescribe antipsychotics as a first-line intervention for insomnia in adults. Done a lot. A lot of people are on what? Quetiapine, Seroquel, right? You'll see this done a lot now. And actually, if you look in some of the sleep literature, even some of the sleep doctors are talking about using this. The evidence for this is pretty abysmal, but is being used in clinical practice, and we do it. And then the final one was don't routinely prescribe antipsychotics as a first-line intervention for children and adolescents for any diagnosis other than psychotic disorders. This one has been watered down some because the child people started to have a fit about this. Well, wait, sometimes I use it. We can't say this. And so, but the evidence for the use of antipsychotics in kids is pretty poor. I mean, there is not any great evidence for using these, but yet we do it a lot. The child people do it. I can say that. I'm not a child person, so I'm not sure what, you know, I'm sure they all do good quality stuff too. Okay. So what's the current state on what's happening? So that's an idea of how some of this stuff is done, the topical areas that come up, the struggles with what to do, why we go to groups to try to get input, so particularly at PCORI, and I will say now at all of these. Those of you who don't know, AHRQ is the Agency for Healthcare Research and Quality. NIH, most of you know, the Federal Drug Administration, and then CMS, which is Medicaid, Medicare, are all in the patient-centered business now. In other words, getting feedback from the end users about what to do, okay? Healthcare systems are also in this. It's driving healthcare systems and the way in which they should be even designed and set up. You're going to see that more and more. Having these patient-centered homes and these kind of things will be in place. Now, what is PCORI? PCORI has basically three things that we're trying to do. Provide information for health decisions. We started out pretty broad. When we first got started 6 years ago, the idea was that we really did want to look in a broad way at patient-centered outcomes and really have patients involved in healthcare, designing healthcare systems, and those kind of things. We have narrowed our focus, quite honestly, over time because we don't have all the money in the world. We have been pushed to really get more specific, and so what you're seeing is that we're focusing more toward these kind of generating the evidence for decisions, and thus the reason for this comparative effectiveness or patient-centered outcomes research. Again, as I said at the beginning, this is not all there is to patient-centered care and improvement of care from a patient and caretaker perspective, but it is one piece of that and an important piece of that. Because without evidence, it's very hard to make a decision about what to do, particularly if you end up with an illness. We would all hope to be healthy all our life and drive us in a direction of being healthy, but unfortunately we end up with illnesses for a variety of reasons. We're also trying to change the way healthcare research is done. So two things. One is we built a very large infrastructure. One of the issues is, as I pointed out earlier, it takes a while to do trials, right? It takes a long time. Is there a quicker, more efficient way to do that that can get you an accurate outcome and a valid outcome? And so we've created a very large infrastructure called PCORnet, and in that is using large data systems. And so to some degree, some of that's already being done. Greg Simon is doing that in many ways right now, but that's the future, folks, of what you're going to see in the future are these large data systems coming together to start to be able to do these large trials and to look at signals, I would say, out of healthcare data. And the other thing we're doing is trying to change the methodology. We actually have a methodology committee that's driving what we're doing in our clinical research to try to change the way in which we really do it to be much more patient and caretaker sensitive. And speeding the use of this information, because as we'd all say, at the end of the day, you can have all the information in the world and nobody uses it, what's the point? But that means involving the patient and the caretaker at the very beginning and designing what you're doing, because I can guarantee you it is not going to be used at the end if you go to somebody and say, use this. So I'll give you a personal story about this. When I told you to go to Mississippi, and then I went back some years ago to be the chair there to see if I could help improve the care and stuff in parts of Mississippi, particularly in the Mississippi Delta, which is a very impoverished area. So I went up to the Delta, and I was talking to this small group, and realized I'd just come from NIH, so I really thought I knew what the hell I was doing, and I just knew everything. So I walked in, and I was telling them, and we were trying to design this study about what to do about depression in a certain group. And in the midst of that, this woman, in a very polite way, which is typical in the South, said to me, "Honey, bless your heart." And I knew I was in trouble, because if you know anything about being in the South, the minute someone says, "Bless your heart," you're in trouble. So she said, "Bless your heart, that's not going to work." And I was like, well, you're telling, I was at the NIH, I was director, how could you tell me this is not going to work? And then she proceeded to tell me why this was not feasible, this was not going to work. So I said, you know what, I tell you what, we'll do it your way. And then, of course, then she was astounded, like we were going to do it her way. But she presented an option that really made much more sense, that was really going to make more of a sense about how to design this and to do it. And we did, and it worked her way. So, and I will tell you, it went a long way also to engaging that population and being a part of it. As long as they took ownership of it, it made a huge difference. So, I learned myself in somewhat the hard ways about what's important, and that listening to people does make a good thing. And I'll tell you another funny story about them also. There was a very prominent group from a Northeastern, very high-profile institution that came down and was going to help them with the obesity problem, right? So they go in and they say, well, you really need to eat more grapes and these kind of things like that. And so you can imagine, so in this small little Mississippi Delta town, the first thing one of the women said, well, first off, do you know what a pick 5 is? And I don't know how many of you know what a pick 5 is, but a pick 5 is 5 things for $5. So that's what you're going to go. If you don't have a lot of money, whatever's the pick 5 in the grocery store, that's what you're going for. And if you go and look at the grapes, they're not very good, first off, and they're pretty expensive in many of these places. So, and it's not part of their cultural food stuff, so they're not going to eat it. So basically, in their other polite kind of Southern way, basically tell them to get the hell out of there and go back to where they were, and they would figure it out themselves. But what did they do? what they did to approach this issue was not get outside of their food culture or what people wanted to do, but to design a program to look at what people like, but to substitute things. So instead of putting pork back into their greens and cooking them, they used turkey necks, which were much more helpful. They also set up their own little garden outside of the diabetes center. And when you came for diabetes stuff, you got a voucher and you could go pick vegetables out of the garden, or you could work back there. And if you weren't capable of doing that, you could get some help to do that. So the assumption is that many people don't know what to do, but they do. And they know in their context what to do. And what I would argue is this is what we're missing often about designing interventions that are going to work and actually be carried out at the end of the day. Okay, so how has patient-centered outcomes research really made a difference? So let me give you some examples of where studies have been changed and the outcome has been changed for what patients and caregivers want. So 2 examples. So one is a study, it's not in mental health, either one of these, but one of them was a study on anticoagulants for people who had a stroke. So people are put on anticoagulant and so the outcome is usually what? What your likelihood of having another stroke or dying, right? So if you don't use it, right? That's not really, if you ask the patients, what do they really care about? That isn't what they care about. Yeah, we don't want to die, but what we really care about is what? How long do we stay out of the hospital? That what matters to me more is what really is going to make the difference for me to stay out of the hospital and live in my home as opposed to some of these other. So the endpoint then became that in the study, and that was more important and actually showed that by using an anticoagulant, you spent more time at home than you did in the hospital. The other one was a study of osteomyelitis in children. And the typical kind of way of doing that was to use IV antibiotics. You sent kids home on IV antibiotics. There's never really been a study to look at whether you should use oral. Now, why is that important? Well, can you imagine trying to manage an IV at home with a kid? I mean, that's a real problem, right? And you get infected lines and you get all these other things. So they changed the study. They were initially going to look at IV antibiotics versus something else, but they decided, okay, we'll compare it to oral antibiotics. Guess what? Turns out, no difference. There's no difference between using oral and IV. So what do you think is being done now? Oral, right? So more people are shifting over to oral, but it makes a huge difference in what people decide to do. Now, I do want to mention this thing about value. That's the big hot topic now. What is value? It is not just the best outcome at the lowest cost. There's more to value than that. Now, the problem is there are a variety of models about this. What should be weighted in the model and all that stuff is very complicated, but at the end of the day, there can be no value without effectiveness. If something doesn't work, you don't even start having a conversation about whether a particular intervention is of value. So this you will hear a lot more about. You've heard about value-based purchasing and all these other kind of things, but you'll hear more about this and will probably be more of an issue that's coming in the future. Changing the way research, I'm not going to get into this, but just tell you that a number of health systems, including Geisner, I think you guys are doing it too, are changing the way in which research is being done so that it is much more patient-centered. And the conversation is obviously changing, I think, in the healthcare system about this. At the end of the day, what's very clear is that if patients are engaged, if patients are activated and are a part of what's happening with them, you have lower lengths of stay, you have better outcomes. I mean, it's pretty clear that health improves if patients are engaged, and also the evidence is much more relevant to what they're doing. Okay, so what have I learned in all these years of doing this and stuff? Well, there are a lot of different genders, and yes, politics is everywhere, and including the pristine NIH is full of politics. So don't assume that there's not politics everywhere, and everybody's fighting for their piece of what's important. And you do have to deal with that. The other thing that I've learned is the flowers don't bloom. What does that mean? So when we first started out at PCORI, we said, we'll put our trust in the academic folks and investigators to come forward with the great studies. Didn't necessarily come forward. You know what I mean? I mean, sometimes it doesn't happen that way, and you have to be much more directive and start out with what's important. And so I think what you're going to see more of is as these topics are decided, there's going to be more of a push. And what we're also doing at PCORI, you will see, is being much more directive in what we want to see launched and done, because people have different priorities, and maybe in their research area, that's what they want to study. And they want. When I was at NIH, I cannot tell you how many times, all the time, meetings on phone, people trying to convince me why their issue was so important. That was the most important thing in the world. Well, it was for them. I understand that. But in the context of public health, in the context of what we were trying to do, it was not. And so I think at some point you have to come to a realization about that. Incentives are in the wrong place. And so from a clinical research, they're not focused on where most of the disease burden is. And so I will tell you also, I'm going to say something about what needs to change in academics, but the incentives are in the wrong place for academics to do research in certain areas and how they do it. You get more credit for the number of papers than the quality of one paper. And I used to say that if you wrote a paper that came up with an answer to curing cancer, it was only one paper, and the joke would be you'd go back to the dean or whatever and said, yeah, but that's only one paper. You got to have 50 to get to be promoted to associate professor. So social and personal context is often ignored. Social determinants are a huge issue, and that one of the things that we often lack and we do not pay attention to is the context in which people live. And without an attention to that, you're really not going to get very far in making a change in population health. So I think that this is one of the things that I've learned, that people don't take this as a perspective, even in clinical practice daily. I work at a place that's very much like Harborview, and what I deal with often with the residents is saying, you can give them antidepressants all day long, but that's not going to change what their housing situation is. And if we don't focus on that, we're not going to do much on their mood right now unless we focus also on that as well. So what I would argue is that this is one of the things that's been clearly ignored, and it's an extreme importance and part of the thing that we need to consider. It's not clear what the mean is when you're trying to be patient-centered, because if you want, the argument is you could go to the nth degree where each person is very individual, but there are commonalities, and I would argue that that is possible. The most important stakeholders are often not included at the wrong point. The issue about patients, they should be at the very beginning. We often wait till the end to say, well, what do you think? Is this a good idea? No, put them at the very beginning as you design something. And as you're thinking about how you put it into place in a health system, they should be a part of that. And implementation should be considered first. If it cannot be implemented and done, then you shouldn't even consider it. And it's not easy to do this. It's not easy at all to do this, to engage. If you're a researcher, to try to get out there and engage populations, get them, especially if you haven't lived with them. And so the lesson I learned is you better go out there and live with people, and you better spend some time with them, and you better do something for them if you want them to be a player with you as well. So they have to feel like you believe in them and that you really want to have invest. You can't go in and say, I believe in you today. Would you sign this form so I can get this grant? That is not going to work. You need to really be a part of that. And so that's one of the lessons that I've learned, and I've taught many of my community-based researchers as well. Okay, so this is the last slide for those of you who are counting or waiting, when is he going to finish so I can ask the question. Opportunities. Despite what you hear, there is a future. Research is not going away. These issues are still important. The second one is there is an interest in patient-centered healthcare system that promotes choice, quality, and affordability. Where do you think I got that? Does anybody know where that quote came from? No, it came off of President-elect Trump's website for healthcare. So, yes, he is the president-elect. You have to be. So, the reason that that's important for you to understand is because the last several years, I've been up, as we would say in Washington when I go there, on the Hill, talking to a lot of staffers and stuff. So the Republicans are still in control of the Congress. There is an interest in this, and I will tell you from the issue often, though, for patient-centered is patient choice. And so there is a big issue about that patients should not be allowed to have what they want. And that's where we get into the cost issue. And that's why PCORI was basically mandated we were not allowed under legislation to address cost, because they did not want us to be pronouncing that something should and should not be done about the cost. That's for someone else theoretically to do, maybe CMS or others. But there is an interest in quality. It's a bipartisan issue is what I would tell you, and it's a bipartisan issue to be patient-centered. So we have patient groups who are Republican and Democrat and whatever, and I will tell you that it's important. That just leads back to the first point, is that despite what you hear, there still is a future, there is still funding. 21st Century Cures just went through, so there is some interest in continued funding. I mean, at least it passed the House. We think it'll pass the Senate. What should you look for? Changing conversations. I think that comparative effectiveness research is going to be an important thing, because people are looking for, how do we make decisions? Where's the evidence for this decision? And systems are clearly going to be much more focused on improved patient outcomes, and you're going to be paid on that. I don't think there's going to be much change in that issue, that you're still going to be paid for showing improvement in what you're doing with patients. Because at the end of the day, if patients are not getting better at doing, why are we paying for this? And I would argue as a patient, why am I coming here and doing this if I'm not getting better? The only other thing I'd say about academic incentives is those are going to have to change. People are going to have to be incentivized to interface with healthcare systems and to understand what they want and what patients want. You've got to be incentivized to doing your research in things that are big problems and not how many papers do you generate. And then the other issue is cooperating with other centers. The opportunities to do larger studies and work with other people is going to be key. So you got to give up some keys to the kingdom. And what can you do? I think primarily on a clinical thing, we don't expect everybody to be a researcher, but you can be a critical thinker. And when you're trying to interface with the patient and make a decision, you should look at what the evidence is and does it apply there, and also engage your patients and talk to them and understand the context in which they live and where that can go. Okay, so that's the end of this, and I'll let you guys, hopefully, we got about 10 minutes. We started a little bit, so I tried to leave 15. You can always send me an email. That's my email, my day job at Emory. And PCORI.org is how you can find out what PCORI is doing. And there are a lot of links to other things on there about what's happening in this area. I know it was very quick, a lot to put into a little bit of a 50-minute talk, but I hope you get something out of it and understand where we're going, and it gets you interested, and in your clinical practice, you'll use some of these. So I'm open to any questions or statements or comments. I've spent many years at NIMH and have been yelled at on occasion. I hope that doesn't happen today, but yeah, one of my first meetings when I was at NIMH, and I stood up, and by the way, we use this term patient, and I know in mental health people would rather use consumer, clients, whatever, but one of my first meetings, I stood up and there were like 1,000 people in the room and stuff, and I was talking and I mentioned the word patient, and this person stood up, and I was like, you know, what's going on? And then I said, oh, I know, I used the term patient, I shouldn't, and she sat down. So I knew quickly what I was not, I learned pretty quickly, you know, so anyway. Okay, questions or, okay, who gets to be the first? That's always the problem. Who's going to, okay, good. Doug, yeah. Well, it's not, nothing's off base. Look, I mean, you know.
We're here at Harborview and here at Grady. We've got an incredible group at Grady that's doing early PTSD intervention. I mean, Carrie Rescue just went to Harvard, but Barbara Rothbaum is still there. But they're still in that very sort of biological psychiatry model, sort of basic science, sort of very incremental. You're sort of head of the Grady healthcare system, and you see the impact on sort of non-addressing context. And, you know, they just got a huge NIMH grant, you know, like $20 million with Harvard at Grady. But it's all about sort of the biological bells and whistles, and can we get this data off a smartphone, and context is really left out of it. And how do you sort of think about that group and you know, it's still a fundamental integration, whether it's PCORI or NIH, the integration of the services perspective, and that's sort of basic.
So basically the question is, how come I don't practice what I preach? Yeah, no, I'm kidding. Yeah, no, so the question was about the fact that I'm at Grady, and there's a large group there who does a lot of great work on PTSD, much more focused toward, if you will, the other end of the continuum on the basic side. How come? There actually is a group, for those of you who know, named Caslow, who does a lot, you know, so who does a lot of work, and there's an intervention called NIA where they're working with this group of adult women and stuff. We're trying to, actually, interestingly enough, you should mention that, is that we are actually bringing together for the first time the whole group who's working on PTSD. So there are the people at the VA, people at Grady, people at Emory, Barbara Rothbaum, and others. And so the hope is to try to bring these folks together to really have the whole continuum of research. Because without understanding the other end of it, they're not going to do as well on the basic side. The reality was the funding is more on the basic side, quite honestly. And I mean, I think that's another issue that I would argue we all need to do, is to fight for what's important from the national level and to try to push the agenda so that it really encompasses the whole continuum instead of just a very narrow spectrum. But thanks for asking the question. Yeah, nothing's off the wall. Yeah. Any other questions? Yes.
Can you speak a little bit to the role of implementation science in addressing some of the access to care issues and you know, models of care, and how to get evidence-based practice into community settings? Yeah, so
the question is about implementation science and how to get basically practice out there into the communities and stuff like that, and evidence out into the community. So, you know, I will say this. We had started out at PCORI doing a lot of work in this area, and we'll still do it. This is politics, so part of the politics here is that we have to share this with AHRQ. And so AHRQ has kind of seen this as their role. They get a piece of what's called the Patient-Centered Outcomes Research Trust, which is where the money goes into this pot, and they get it to do this. And so we've had some back and forth with them about that. But the lesson, I would tell you that the key lesson that I've learned about implementation science, having kind of lived it, as I said, in the Delta and other places, is that if you really want to get things used and you really want to, you have to start from the ground floor when you design your effectiveness stuff, and whether you basically design what the information is to work with people who are going to use it. And so I think where the implementation models at work are is where they actually get people who are the end users to be the proponents of it, get involved in it and use it. That's a nutshell kind of answer. It's much more complicated than that, to be quite honest with you, because some people decide not to do things for a variety of reasons that are not clear always. And I would say, you probably know this better than I do in the behavioral health science. I mean, there's a lot to learn on the behavioral health science side about why people do and don't do things. And I think in services research, what we would argue is there are a lot of reasons systems don't do things, but there should be a rationale to that. People are not completely irrational, you know, and so what is it that's driving them or not driving them could be very helpful. It's an open area. I will tell you that there's a lot of interest in doing research in this area, so there's no clear answer, but there are opportunities, I would say that. So maybe that's a better answer than the one I could have given, is that you could have a life in research on this. Right?
The funders that are most interested are
well, AHRQ has been, NIH has gotten into the business, is what I would tell you. They understand it well, and even CMS and others who understand that it's pointless to say to do something if people are not going to use it. Even, you know, FDA and others understand it. So I think what you'll see is more of an attention to this, and health systems certainly are pushing this as a big issue, because for them it's really critical. Right, especially if you're going to be judged on doing something and you're going to get paid basically on whether the outcome is what we want. You better figure out how to get that outcome. I mean, you know, and get people to get better, basically. Yes.
Yeah, I understand Emory and Grady have been leaders in the health system zero suicide initiative. Is your group in the research arm?
Yeah. So the question is about Grady and Emory and suicide prevention stuff. And so part of that comes out of some of the work that we've done at Grady, particularly in the NEA project, where they have a specific focus on adult women who've been traumatized and certainly are at risk for suicide, and where they work with them. Dr. Caslow's been a big leader in this, and I think we've been trying to move more on that. For those of you interested in suicide, the 21st Century Cures bill that just came through the House and is probably going to pass through the Senate, we expect, has a chunk of money in there for suicide. Now, is it primarily just to put models out there that we think are going to, but there may be some research in there as well. So there's a huge national interest in trying to do something about suicide and suicide prevention. Okay. Anything else? I think we have to stop. Right?
Yeah, I just want to make sure there's nobody at the U that might have.
Oh, that's right. I should have. Yeah. So you had the picture up there and I didn't pay any attention. Well, they were holding their hand up.
Okay.
Okay, now, are we all right?
Yeah.
Yeah, okay. All right, I know you all want to leave. It's Friday. I know how that works. Yeah, we do. Thank you.